So good afternoon, everyone. Welcome to this OpenPrescribing webinars. This is directed for arm's length bodies based staff. So thank you for joining us today. Right, okay, so we are mostly talking about primary care prescribing data when we think about OpenPrescribing, or at least we are at the moment. So it's important to kind of know where this comes from and what's happening. So we think about the general flow of prescriptions. So a prescription is written GP practice for a particular medication. It's then sent to a pharmacy, mostly electronically is the way that it's done these days. So the pharmacy receives a prescription, processes the prescription, supplies the medication to the patient. Then obviously they need to be paid, both for the service that they've done and for the cost of the medication they've supplied. So at the end of each month, the pharmacies submit their prescriptions to an organisation called the NHS Business Services Authority, so NHS BSA for short. The BSA's job is to collate all this data together, so they get all the prescription data together, and then they process these and use this to pay pharmacies accordingly for the services they've done and for the medications they've supplied. As kind of a byproduct of this, the BSA ends up with a huge amount of data. So they have data on, what prescriptions were issued for what patients, what drugs they were for, who prescribed it, who dispensed it, what the quantity was, say, on prescription, how much it cost. So lots and lots and lots of data every single month is accumulated by the NHS BSA. Thankfully for us, they make some of this available. So this is the main data source that we use in OpenPrescribing, the NHS BSA English prescribing data. So it's an anonymized data set, so it doesn't obviously include everything that the BSA hold, but it does include things like patient information, patient level data, because obvious and kind of anonymity reasons, we can't be putting patient details online about what medications they're on. But it does tell us what individual GP practices have been doing. So it tells us, this GP practice has done this many prescriptions for this drug and this many for this drug, and this is how much they've spent on this. So it gives us lots of information to kind of make a start on and make a go of. Updates come out every month, so there is a new kind of release from the NHS BSA every single month with data. Normally comes out about the middle of the month, about the 20th of the month, something like that. There is a bit of a lag time though, so it's about 2 months that it takes for it to come through. This is just while they kind of accumulate things, process things, clarify missing data and confusing data. So, for example, in about 2 weeks' time, around the 21st of October, we'd be expecting August's prescribing data to come out. So just if you're looking on OpenPrescribing, don't expect the current month or the previous month to be shown. It might be a couple of months behind. Because that's how frequently it's published. There's a couple of definitions it's important for you to know. So we try not to get too technical, but these are the kind of the definitions that are laid down by NHS BSA and are important just to be aware of kind of what they mean and a little bit about the complexities of them. So items is basically the number of times something has been prescribed. So if we think about amlodipine 5 milligram tablets as an example, 2 items for amlodipine 5 milligram tablets means that there have been 2 prescriptions for amlodipine 5 milligram tablets. So it tells us there's 2 prescriptions. It doesn't tell us how many, say, tablets or anything more than just there's been 2 prescriptions. So this is where quantity is the kind of the other measure that's used. So this is the total amount of a medicine that has been prescribed. So in that example, amlodipine 5 milligram tablets might get a quantity of 56, which would correspond to 56 tablets. So a prescription has been written for 56 tablets of amlodipine. It's all quite straightforward when we're talking about things like tablets and capsules. It does get a little bit more tricky when we're thinking about other formulations. So things like liquids are often the quantities measured in mils rather than kind of solid dose units. So just definitely need to be careful if you're adding up quantities, because adding together the number of tablets and the number of mils of a liquid of a different strength won't give you any kind of sensible information. So just a little bit of care needs to be taken with these. So this is a very kind of a small snapshot of what the data is published looks like. So this is the NHS BSA data. I think this is in our own database, but you can see there's lots of columns with lots of information. So lots about where the patient was located, so things like what region they were in, which ICB they were in, which practice they are registered with, what drug was prescribed, and then things like quantity, items, cost that we talked about. These are pretty big files though, so this is a very, very small number. I think there'd be millions of rows in each month's file. Each runs to about 6 gigabytes. So you could just about download, say, July's data on your own computer at home and open it in Excel. But you would struggle to do too much in terms of analysis. One, because I think Excel would be running particularly slowly. But also you'd only have 1 month of data, and there's, I think you'd find it impossible to open many, many months of data all at once. So this is where OpenPrescribing comes in. So we basically take these huge data files and we, one, present them in a way that facilitates benchmarking, which I'll go through in a bit. And we also make it available for further analysis. So we make it easy for you to use this data to kind of draw your own information out and draw your own conclusions. For those of you that haven't used OpenPrescribing, it is openly and freely available for everyone. So you don't need to log in. In fact, there is no login option. You go straight onto the website and you can click through to everything. So it means you can share links with anyone that you work with. Patients can access it, so public patients. It's open to anyone, and lots of different people do use it. We have about 20,000 unique users per month that use the OpenPrescribing website. Majority of these are based in the NHS, we're fairly sure, and lots of them are based in ICBs. So they're kind of the teams that are there to make sure prescribing is well managed in primary care overall. But we know there's lots of other user types. So in individual practices, there's GPs, pharmacists, practice managers who look at what's happening in their practice. Or there's people from lots of other organisations as well. So I think we've got some people from NHS England here who are obviously overseeing everything. Other arm's length bodies, we know, people like NICE might be interested in certain bits, which we'll touch on today. Drug companies, reporters, so it's open for everyone and lots of different people use it, and we want to make sure basically everyone can get out of it what they want to. So the idea is that we can sort of benchmark prescribing, have a look at what's going on, use it to help identify areas where maybe improvement could happen, or to prompt discussions and action about where things need to improve. A little bit more on the technicalities. So if you look at different data sources, so obviously OpenPrescribing is one thing, you might use other things like Prescript or ePact, two other kind of common prescribing sources that show data. You might find the numbers don't exactly match up. So we all kind of make our own analytic choices about what's important and what's not important. We only really look at GP data, so we filter out things like out-of-hours centres or urgent care centres. We also use monthly data rather than 12-month rolling data. So on the screen, you can see there's a couple of different charts that show data in slightly different ways. So this is looking at broad spectrum prescribing as a percentage of all antibiotic prescribing, broad spectrum antibiotic prescribing as a percentage of all antibiotic prescribing, sorry. So you can see this is showing roughly the same data, but one is kind of stretched across 12 months. So the one on the right you can see is kind of a steady increase and then drops back down, whereas you can see the monthly data shows some fairly rapid changes. So one particularly interesting one is this one here. Hopefully you can see that. So in December 2022, you can see there's a very sudden drop in the percentage of broad spectrum antibiotics, where you can't really pick that up on a 12-month rolling chart. We do know so there was a big outbreak of Group A strep at the time. So actually, it was just that lots and lots of prescriptions being written were for non-broad spectrum antibiotics. But that's something you might miss if you look at 12-month rolling data. So that's why we pick one and we stick to it. So just be aware, you might not find the exact same numbers, but we're probably using a very similar data source and very similar data. It's just there's a little bit more complexities behind what's shown. Right, okay, so I'm going to move now onto the practical demonstration. So let me just close that window. So you can go to the OpenPrescribing homepage. So I think Hillary's already shared it in the chat, but openprescribing.net is our standard homepage that you can go straight to. I'm going to go reasonably slowly today, so if you want to open it up on your computer at home as well and have a click along, then you should be able to do that as we go through, or you can have a look at the recording afterwards as well if you need to catch up or you want to catch up on a few bits. So from this page, there's obviously on the right hand side there's our latest news. So here we write about maybe changes we've made to the website, changes we've seen to the data. Or something interesting, we've identified something interesting that's happening with prescribing. So there's been some changes to which DOACs, like an anticoagulant drug, is the preferred one recently. So we've changed our measures and things on the website just to reflect kind of changes that are happening nationally. So from here, probably the main thing you want to click through to first is this area and practice dashboard section at the top. Again, because because we're looking at arm's length bodies today, we'll just start with this one here. So this is All England view. So I have already opened this just because it does take a couple of seconds to load. But if you click through to the All England view, it should bring you to a page that looks a little bit like this. Pages for different groups are very similar. So you'll see very similar layouts for, if you're looking at ICB level, if you're looking at a PCN level, if you're looking at a practice level, you'll see fairly similar data throughout, however you look. So the first thing we're going to have a little look at and talk about is measures. So these are things that we think are of importance or of interest that we can represent through prescribing data at the level we have. So obviously we don't have patient level data, so we can't say, this patient's on these two drugs together and they shouldn't be, but we can pick out generally just individualized things about a single prescription. They're not just things we've made up off the top of our head. So you'll see we have this section here against all these measures called Why It Matters, which is a bit about why we think this is an important kind of indicator or measure of what's happening. And we will normally have a link or at least one link to some national guidance or international guidance or something to back up why we think this is important, why it is a thing of significance to be looking at. On the charts, I think this is a slight, obviously when we look at an All England level, it's slightly unusual because the red line shows roughly what's happening at the level of the organisation you're looking at. Obviously, if we're looking at All England, then All England is going to be about in the middle for every measure, just because that's the nature of what we're looking at. We're looking at everything, so on average, it should be in about the middle. But you see there's lots of different lines on the charts. So the blue dashed lines are what we call the national decile. So these represent, say, the 10% of practices, 20% of practices, 30% of practices below these lines. So basically, essentially, you want to know, are you in the top 90% of prescribing for this? Are you in the bottom 10%, or are you somewhere in the middle? Don't think you can see it very well there, but underneath this red line is a blue dashed line as well, which is kind of the middle. So the fifth decile, or the national median. So where about 50% of practices are performing. So if you're under that, you're under what's happening. If you're above that, you're over what's happening. We work on a principle generally of low is good. So the lower you are on this measure, so the lower you are on the y-axis, generally speaking, the better things are going. It's not always to say that being high is terrible or something's going wrong. There might be obvious reasons, specific patient makeup, things like that. So there's definite reasons why you might be slightly higher than other organizations. But I think it's useful to at least highlight it, and then for individuals to kind of have a think about why they might be an outlier. So if I scroll down here, you can see there's lots of different measures. We've got somewhere about 100 overall across the website. I think one of the ones, I think I did scroll down a little bit earlier, so one of the ones that probably is a little bit more interesting than some of the others is this one here called, so looking at course lengths for amoxicillin 500 milligram capsules. So amoxicillin is an antibiotic, for those that are not aware. And there has been a kind of a move towards shorter courses of antibiotics, because we know short courses probably are as effective as long courses for uncomplicated infections. And we know giving people long courses of antibiotics can be a driver for resistance. So we click through from here, we can click through to things like, I know this is not the right measure, but you can click through to compare all sub-ICB locations in England on this measure. And it will take you to a page that looks a little bit like this. So this then shows what's happening across lots of different ICBs and where they're at. All of these are ordered from highest to lowest. So the one at the top will be the one with the highest value, and the one at the very bottom will be the one with the lowest value. So we can see NHS East Staffordshire here has got quite a high number of prescriptions for longer than 5 days. So 67% of their prescriptions are for longer than 7 days, for longer than 5 days. So it's interesting that that's happening. Is there a reason why? And what has everyone else done? If you have a little bit of a scroll down, you can see it does varies quite considerably about what's happening. So this is 67%. If we look, the bottom 10% of practices are doing somewhere around, I don't know, 20, just above 25%. So that's quite a big difference in how organisations sub-ICBs are performing. And you can see that as we scroll down, you can see that lots of them have started. So this one, the one that we're looking at the top, is slowly starting to drift down. So that is reducing. But we can see some of them have made fairly sudden improvements. So here, NHS East Sussex has gone from about 70% down to 56% fairly rapidly. So you can have a scroll and see, but it often just indicates that something sudden has been happening, especially when it happens on like a sub-ICB level. Then it's obviously quite coordinated. So here, South East London has made quite a sudden and dramatic improvement to about average, from much higher than average. Let me just find that measure. Here we go. So this is the measure we've been looking at. So you can compare all sub-ICBs. You can have a look at individual presentations. Probably not that interesting for that one because it's all going to be amoxicillin. But if you wanted to know, say, what the different things that were being prescribed are, let's have a look at this one above. So volume of antibiotic prescribing. So we can click through to that one and we can see under the chart, it tells us what different drugs make up that measure. So we can see here amoxicillin is, in terms of both items and quantity, the most prescribed antibiotic, covered in that measure by a little way, but there's others that are not far behind. Right, and then when we click through to these, we can have look in even more detail. So maybe you've identified that NHS East Staffordshire is particularly high in this, but we want to know, is it high everywhere or is it high in just some practices? So again, you can split it down further into individual practices. Click over to that page. You can see there's definitely some practices with really high levels, 95%, 85%. So they're always going to be at the top, and then we scroll down and we can see there are other practices which are much lower. So this practice looks like they've definitely made some changes. That number has very suddenly dropped to around 15-20%. So it's not across the whole ICB or sub-ICB, it's across kind of certain key parts. Let's have a look, click through. Yeah. Okay, so we can see that there's a little bit more going on there. One of the other bits that we have on our website, I'm just going to skip over to this because it's probably relevant at this stage here, is this section here called the sub-ICB level improvement radar. So this looks at the measures and helps us highlight maybe places where they have made sudden changes. So sub-ICBs where they've made sudden changes. So again, looking at this one in particular, so courses for amoxicillin greater than 15 days, we can see it's picked, or it's highlighted 5 different organisations that have made fairly rapid changes. So they've obviously implemented things there that have changed things. So we can see this measure has dropped down suddenly from somewhere in the 70s to somewhere in the 40% quite rapidly. Here you can see there's a really steep change. in Warrington, well, 2 steep sudden drops. So maybe it's 2 different initiatives that have happened, and here NHS Devon just 1 huge drop. So that's a useful tool just for having a look, seeing if there's maybe initiatives that are going on across the country to improve certain things that we cover in the measures. Right, going back to the measures, what I will do is I'll show you, if we go into a sub-ICB, it sometimes makes a bit more sense when you're looking at things. So we can see here that the red line is very different from the one in the All England measure, because this is just looking at one sub-ICB. And again, here we can see they're ordered from kind of where the numbers are highest to where the numbers are lowest. So these are probably areas where maybe changes could be made, or definitely things could be reviewed to see if there's things that could be improved. But actually, if we scroll to the bottom, here we're saying things are going well here. So no prescriptions for methotrexate 10 milligram tablets, which we would generally say is probably a good thing to avoid confusions to patients. So it's not all about the bad, it's about the good as well. And often there's a mix of things. And then, like I said, there's always going to be outliers for everything, whatever we do. So it's just about reflecting on reasons why that might be the case. If you look after certain things, or you have certain specialist interests, you can filter our measures as well. So there's this show measures categorized as. So we link down to categories. So say things like you might want to know what we're doing with the national medicines optimization opportunities. So we've created lots of measures that are based around the targets in these. Again, things like the amoxicillins in there, but there's lots of different areas, things like environmental impact of inhalers. DOAC prescribing, I think, is one I mentioned we've updated recently. So there's lots of different things shown in here that you can filter down to depending on what area. So I'm sure lots of you only work in one specific area, or definitely don't have an interest in looking at every measure. So it might be worth just using this categorize as to kind of get a quick view of what you're interested in. Right, and then going back to All England, we also have this other section, which is low priority prescribing. So this is the NHS England items that should not be routinely prescribed list. Again, would look, I think it might take a little while to load. So again, looks fairly similar in terms of measures. It's just a slightly, obviously it's a very specific list of things that we're looking at here, and there's a very specific reason we're looking at them based on NHS England guidance. But you can have a scan through here so you can see what's happening again on an All England level, and then you can maybe have a look at individual areas and see what's happening there. So here we're looking through All England, but you can do the same thing. Say if you work in a region, you can do the same thing for your region only. So if we look at, say, Midlands, you'll see it looks fairly similar. So we've got measures over here and low priorities over here. So you can look at that, and you can, again, you could click through into measures. You can break down into, say, the sub-ICBs in that area or in that region, and you can have a look at those in more detail. So lots of different ways to break things down. It just depends on kind of your starting point and your interest area and but you can definitely, I would say, start with the measures and pick through and find things that are interesting there. Some of the other things that we do, so I mentioned data comes out once a month, around the 20th of the month. Obviously, we don't expect you to keep an eye on the website all the time to know when things are updated. So we do offer these email alerts here. So if you scroll down onto our website, you will see a section on each of the pages for each of the different organisations, allowing you to get monthly email alerts, which will basically get sent through every time we've added some new data. So every kind of middle end of the month, we will send you an email saying the data on OpenPrescribing is updated, and here is what's changed, or here is what's showing. So if you prescribe at, say, an ICB level or sub-ICB level, you'll get information about what's happening, which measures that organisation is performing well on, maybe areas where there could be improvements made. So it kind of keeps you updated and helps you keep track of what's going on. So I would say it's definitely worth signing up to that, if nothing else, just as a reminder to keep an eye and keep a track on what's happening on OpenPrescribing. We have some other tools as well on the website. So this one here, PPU cost, or price per unit cost. Again, we can click through into this one. Sorry, I'm opening lots of tabs because it does take a little while to load. This one, yeah, takes a couple of seconds to load. But this is a useful one for identifying possible cost savings. So we know generally in the NHS, the guidance is that everything should be prescribed generically, because generically prescribing things is the cheapest way, which is mostly the case, but not always the case. So there are certain things that actually, if you prescribe, say, a specific brand or a specific formulation, it might be cheaper. So some of these things look at brand in particular. So if we look at this top one here, so it's an inhaler, so beclomethasone formoterol. So this shows us roughly what's been happening across the country, and we have different lines and different dots. So here, the top line is this inhaler being prescribed generically. So it's this big red dot here. So there's been 10,000 items at a cost of £29, basically, possibly units is inhaler, but about £29, I think, per inhaler for that one. And then you can see the next line down is Foster, which has got the biggest red dot. 370,000 units. £29.32, so it's the same price. So basically, if you prescribe generically, it's paid at the same price as this Foster here. But then if we move down to the next line, we can see that there are these other slightly smaller dots, so Lufabec and Bebecfo, which have so they're the same components, so the beclomethasone and formoterol, and the same strengths, but they're different brands that have come out fairly recently by different manufacturers and are cheaper per unit. So this is £13.98 per unit, and £13.98 per unit. So you can see significantly cheaper than the Foster one that's going out there. I think lots of areas are probably starting to switch over to use more of these cheaper products at the moment. There are other ones on there, so things like this one, you might see a little note next to it. So cocodamol capsules, it tells you how much could be saved, but it tells you the reason why. So this is a capsule tablet switch. So basically this is saying if cocodamol was to be prescribed as tablets instead of capsules, this is the saving that could be made, so £674,000 across the year. So not insignificant. These all add up. I think when you look at it across England, they add up quite rapidly into the millions. When you look at it at practice level, some of them can be zero, so some practices might have already implemented these. But it's just useful to see across a big scale where the savings could be made. We are not saying all of these should definitely be made, so there's certain kind of reasons why you might not change things. Maybe, I don't know, patients have tried the other inhaler and they didn't tolerate it, or there's problems, or they can't swallow tablets, and they can only get on with capsules. We also know prices fluctuate quite a lot, so it's not a quick thing to change 300 patients' prescriptions to tablets instead of capsules. So it's worth a thought about, is this going to last? Is this the right thing for patients as well as financially? So it's an indicator that maybe there's something happening there, but it's not a you must do this type of thing. Okay, right, going back to the All England page, one of the other things that we show on our website is price concessions. So very briefly, I think Hilary been sharing the blogs, which have lots more detail, so I'm trying to cover things in a few sentences here, but if there's things that you think are relevant to you, I would say definitely have a look at our blogs where we write lots more kind of detail and context. So price concessions. So generally there is a document in the UK called the drug tariff, and this sets out a standard price that a pharmacy will be paid for a specific medication that they supply to a patient. There can be certain circumstances where the drug is not available at that price. So perhaps all the generic versions of that drug that are cheap go out of stock, and only the branded version is available. At that point, obviously, the price is likely to go up. And a short-term agreement is made for NHS England and Department of Health to repay pharmacies at a slightly higher price to cover the cost, or some of the cost difference that's happening. So it means that for some months we might pay slightly more for drugs just because they're harder to get hold of and not possible to get hold of them at cheap prices. It can be quite variable as to how significant these things are. So sometimes the drug is quite a small, has low numbers of prescribing. So might be, there's only 100 prescriptions across the country and it's only a couple of pounds different, so it doesn't add up to much. Sometimes it can be small numbers, but the cost difference can be quite significant with the price concession. And sometimes it can be something that's really, really widely prescribed. So the even a small difference in price adds up quite quickly. So in this tool, we kind of try and keep a track of what's happening with these price concessions and produce an estimate of where things are likely to be. So I said earlier, we don't get exactly the latest month of data, so we get data a couple of months behind. So on our website at the moment, the latest data that's available is July, but we do have information on what drugs are on price concession in, say, August and September. So we've made estimates about how much price concessions have cost across the NHS in England, based on kind of historic prescribing numbers and based on what the price concession quantities are. So if you scroll down here, so if we look here, it's probably somewhere around somewhere between 27 million and 35 million in August and September. Obviously, these turn blue when we've got the data and we can have a much better idea of what things are at. But these are the ones this month that are impacting things. So apixaban is a fairly big one because it recently went generic and the price very rapidly dropped, with generic versions becoming available at much, much cheaper than the brand. But then I think lots of these generic products have disappeared. So the price has suddenly gone quite a long way back up towards what it used to be. So this is probably a case of fairly widely prescribed and also a big, big cost difference, and it does add up quite quickly. So here the difference is about £6.5 million a month that this is costing. And again, different prices, different strengths of apixaban. So again, this lower strength, £2.8 million as well in a month. So again, the price concessions add up significantly. So we keep an eye on them. We try and identify things. It's often, obviously, there's not a lot that can be done. So they tend to be short-term 1-month agreements. It tends to be issues resolved fairly quickly, or issues change quite often. So it's not often a case that we would change someone off apixaban just to avoid this cost. It's sometimes just about being aware that there is this financial impact happening. So again, if that's an area you work in, it's really important you probably have an idea of what's happening here. So we have email updates that you can get. So you can put your email address in here and you'll get an email basically saying there is new price concession being agreed or new price concession data out. Here is what we're estimating the cost will be, and you'll get an email. Normally when the new price concessions come out, I think they're probably slightly less often weekly at the moment. So I think probably every couple of weeks you might get an email just saying these are where things are at. So again, if that's something you're looking at, if that's an area that's important to you, I'd say it's worth signing up to our email alerts for that. Right, then moving on. So one of the other tools that might be useful to you is the Analyse page. So on the Analyse page, you can basically have a look at your own things of interest. So you can have a look at, say, different BNF sections or different drugs, and you can get an idea of what's happening, and you can use different denominators or look at different things. So one of the common examples we use, definitely not a common drug, is a drug called perisciazine. So we use this just because it's a fairly kind of stark example of differences. I think most things you won't find such major differences, but it's a useful one. So perisciazine is an antipsychotic drug. So we can put in perisciazine here, we can put in versus nothing, and we can look at, say, NHS England regions. So this gives us the number of items for this drug across different regions. So we can really quickly see that East of England Commissioning Region does a lot of prescriptions for this, 4,000 in July, whereas most other places do very few, if any, 100 or less. So it looks like it's really, really kind of isolated to the East of England. there can be reasons you might come across for things like this. So I'm not saying this is true, but you have to be, obviously different regions have different populations. So maybe they've got lots more patients in the region that pops up high. Or there might be differences in prescribing. So obviously this is an antipsychotic. Maybe in all the other regions, the antipsychotics are prescribed by the specialist mental health team. And in this one region, it's all prescribed in primary care. So this is where you can use the denominators. So to account for, say, the population, you might do it versus total list size. And if we rerun it again, yes, we can still see that there's still that big difference. And then you might also want to say, okay, so what is it as a percentage of all antipsychotic prescriptions? So this would say, you know, if maybe all antipsychotic prescriptions are written in secondary care everywhere else, then we would expect it to kind of even out. But again, it's still a big outlier here. So you can see it's a long way off. If you want to see it in a more obvious way, you can see it on a map as well. So you can see a big red mark. There might be reasons why this is the case. I don't think we've ever got to the bottom of quite what's happening there. No one seems to have an answer. But that's a really obvious example of picking something out and working through it. Maybe you're interested in certain new drugs that have come out. So one of the new drugs that I've been keeping a little track of is tirzepatide. So we can see, let's go back to regional teams. So again, we can show this is spread out across regional teams here. So we can show definitely all regions are doing some prescribing for it. And we can see again on the map. So there's certain areas that are higher, certain areas that are lower, but maybe that's just because they've got different list sizes, so different numbers of patients in those regions. So if we rerun it, yes, we see that the colors change. So when you account for list size, it's definitely different. And maybe again, you want to do, say, so it's drug used in diabetes predominantly. So if you want to look versus anti-diabetic drugs, you can put it in that way. Can have a look, see. So Southwest seems to be the place where most of the prescribing is going on. Southeast and more north, less prescriptions going on. Those are some examples. I think if you look after a particular area or there's something you're interested in, then you can definitely play around and have a look through. I'll leave that in. You can look at time series as well. It's probably the other interesting one. So this only launched, I think, February, March time this year. So you can obviously see it went from nothing to quite a lot. Obviously, this y-axis changes depending on what you're looking at. So don't read too much into a sudden sharp increase because the y-axis will adjust, but it can give you more information if you're interested in what's happening with something specific. The Analyse page is somewhere to go if it's not covered by a measure. And you can change what sort of level you're looking at here as well. So some of these plots get messy if you're looking at all practices, but if you're looking at one specific practice, then you can filter it down that way. Right, okay, we're coming towards the end. So I've got a couple of last bits to cover, but like I said, if you've got any questions or anything you want me to cover towards the end, please do put it in the question and answers, and we can cover it there. So other things that might be useful to you in kind of depending on where you work. So we've got this trend section here for other different tools that we have. So we've got trends by B&F section. So this basically tells you what's happening across different B&F sections of how much, say, either spending or number of items is happening across the NHS in England. So I think, again, we'll go back to anticoagulant medication because there's interesting things happening with prices of those. So oral anticoagulants, so we can pick there. So we can see expenditure on oral anticoagulants definitely went up and up and up and peaked about 72 million and then has started to drop quite significantly over the last probably year or so as generic versions have started to come out for some of these drugs. So I was showing you the price concessions earlier saying, we're spending 6 million more on price concessions per month, but we're also spending probably 30 million pounds or less a month on these things as well. So it's a bit about taking it into context as well about what's happening more widely. So you can look for B&F section similar. You can look for chemicals as well. We've got this section here, which looks at the drug tariff. So that's what I mentioned about how much is paid for, say, specific medications, how much pharmacies are reimbursed. So again, let's use apixaban as the example for everything. So we can put in apixaban 5 milligram tablets. And here we can see the trend of the price that's paid for apixaban over time. So this is when it first came out, £61.50, dropped to £53, probably as more became available or different ones dropped their price. And then we can see there's this really sudden drop here. So it went from category C to category M, which is when it started to become available generically, I think. And so it went down from £53.20 in June 23 to £2.83 in May 24. So over a short period of time, the price dropped massively. So we can see that's always been low, but we do also plot things like the price concessions on here as well. So this green line here shows that there is a price concession